My name is Lon Melnick.
I'm Rajiv Tandon. I'm a professor of psychiatry at the University of Florida.
And I am Lon Melnick. I'm a psychiatrist in Miami, Florida. I do quite a bit of things, but we'll discuss as we kind of go through. And today we're going to talk a lot about improving long-term outcomes. I guess we need to get the clicker. We're going to talk about long-term outcomes in schizophrenia. We decided early on that we were going to do somewhat of a review, a better understanding of how we can use not only medications in schizophrenia, but especially in long-acting injectables, and more or less where they're going to be in dealing with this. So, like I said, my name's Lon Melnick. I'm a psychiatrist in Miami, Florida. I run 4 private offices in Miami, Florida. I do apologize. I know I look like I'm 12 years old. It is a horrible existence. I do blame my father. It is all his fault, as therapy has actually taught me nothing is my fault, so that actually helps. But really what I am is give you guys a different perspective in dealing with this. One of the things that I do is I do run the largest forensic community control program in the United States, where we transition patients from the forensic state hospitals into community, and we follow them for the rest of their lives. And so one of the things that we've done is been able to use a lot of long-acting injectables, and in doing that. Rajiv?
You know, Ilan, unlike you, who look 12, well, enough said. I've been a practicing psychiatrist for about 40 years, and I've been conducting research primarily into the neurobiology, pharmacological treatment of schizophrenia for almost that time. And, you know, as Ilan shared with you, this is going to be more in the nature of an informal overview, touching upon key points that are relevant in terms of improving outcomes for persons with schizophrenia, particularly in the context of longer term, not acute treatment as much, but the more chronic long-term phase of schizophrenia. Ilan, should we go through the disclosures?
So these are our disclosures, and understanding that this is a CME program, so we have no relationships to disclose relating to the subject matter of the activity. So if we do our job right, we're going to hopefully recognize patient and physician-level barriers to effective long-term schizophrenia management. We're going to examine the latest clinical evidence regarding long-acting injectable antipsychotics, including their psychopharmacological profiles and impact on medication adherence. In the pamphlets that you all have, there are the slides, and there's going to be a really great review on all the long-acting injectables that are currently available. We're going to translate clinical evidence into informed and individualized treatment selection, monitoring, and management in schizophrenia, and develop schizophrenia management strategies that address patient non-adherence and support the coordination of care and transitions.
So let's start with a discussion of what are we trying to do in the context of long-term treatment of schizophrenia. What are the needs? What are the challenges? And what tools do we have? And how can we best use them? So I did not have any financial conflicts of interest, but I do have a couple of conflicts of interest to share with you which are relevant to the discussion, my discussion today. As I shared with you, I've been a practicing psychiatrist for almost 40 years. And as a clinician, I really like seeing my patients get well. And I do anything and everything to help them get well. But the challenge I sometimes have is I think that anything and everything that I do for my patient, because it's so well-intentioned, is always helping them. But there are times when the patient is actually getting worse or not getting better when I think they're getting better because I really so badly want them to get better, and I'm doing everything to help them. And so that's a clinician bias that one needs to be cognizant of. And measurement-based care, measuring the impact of what you're doing on your patient and having that as a guide is helpful. And I've been conducting research in schizophrenia for almost that length of time. And as a researcher, I want data. Give me information, give me data. One of the challenges with data is if I pick and choose what I'm going to share with you, I can tell you almost any story that I might want to. Now, I mean, those of you who follow the news, the smart ones amongst you probably don't watch any news these days, but depending on your political persuasion, you know, there are different news that, you know, each we receive, because there's only part of the information that's provided. So really important to look at all available information. And secondly, researchers have a tendency to wave their hands and, you know, maybe this, could be that, possibly this, a lot of speculation. And as a clinician, I know I want hard facts. Don't give me all this fanciful stuff. Hard facts, and present them simply, because the information you give me, I'm going to try and apply to the care of the next patient. So those biases I did want to share with you. One of the advantages of having spent a fair amount of time in the practice of psychiatry, being old, in other words, is that you'll learn a few things along the way. And one of the things that I have learned is the practice of medicine, psychiatry in this case, treatment of schizophrenia in this case, is really, really simple. It just involves knowledge of 3 sets of facts. The first set of facts is, well, I need to understand the condition that I'm treating, how to diagnose it, what its nature is, what the clinical course is, what happens if you don't do anything, what happens to people with that condition, if you don't do anything, what's the biology of that condition, what do we need to correct, so that we can identify targets of treatment and goals of treatment. The second set of facts that we need to know is, so what tools do we have? What treatments are available? Do they all work equally well? Are they different? Do some work in some patients and others in other patients? And can we tell at the outset which is going to work in which patient? Do some work on some aspects of the illness and others on other aspects of the illness? So how do they compare? And what are the costs? Side effects in particular, how do they compare? And the third thing we need to know is, we know what we're trying to do, we know what tools we have. The third set of facts is we need to know how to use those tools well. And really, one of the things that I as a psychiatrist and we and our field at large has not done very well is use the tools that we have as best as we can. And the bottom line really is target treatment. What are we targeting with any particular treatment? And that's why the first set of facts is useful, to think about what we need to target. And then we think about, we're using this treatment, what are we targeting with it? The second principle is measurement-based care. So once we've targeted something, well, we need to measure what's happening to that target. I mean, think about a person with a urinary tract infection. After you culture, you give them an antibiotic, but then you repeat urine analysis to see if that particular treatment has been effective. And so what are our tools? And what I'll share with you is we do have tools that are relatively simple and very useful. And then we can individualize treatment. So we'll come back to these 3 principles: targeted treatment, measurement-based care, and individualized treatment. So, nature of the illness. What do we know about schizophrenia? Schizophrenia tends to begin in late adolescence, early adulthood, a little later in women than in men. You have the first psychotic break in late adolescence, early adulthood. But persons who go on to develop schizophrenia have also exhibited some degree of premorbid dysfunction. They're shy. They don't do quite as well at school. They don't play with their peers. They're somewhat anxious, which is why, if you recall, 40 years ago, 50 years ago, we had this term schizophrenic mother. Well, the mothers of persons who go on to develop schizophrenia do tend to be somewhat more protective. But that is because who knows a kid better than the mother? So the mother can sense my child is not doing quite as well. is vulnerable and hence somewhat overprotective, if you will, because of that. It's not a cause of schizophrenia, In fact, one of the things I'd share with you is psychiatrists tend to be extremely imaginative. Not only had we coined this term schizophrenic mother, there was a Swedish psychiatrist, Olanen, who had coined the term schizophrenic grandmother, something about grandmothering that leads to schizophrenia. Not true. None of that is true. So getting back to premorbid, so first psychotic break, usually late adolescence, early adulthood, and then you have a remitting relapsing illness, tends to be chronic in about 90% of people, and the remissions tend to be incomplete and significant impairment of social functioning. About 1 to 5 years prior to the first psychotic break, you see prodromal symptoms. And since the deterioration, both the brain deterioration as also the functional deterioration begins during the prodrome, we've been making efforts to try and identify the prodrome and see if there's something we can do to help people during that period of time. Because oftentimes when patients come to us for their initial treatment, and that's usually a lag of about 18 months in our country from the first experience of psychosis to the first presentation for treatment. So you've got an 18-month lag. It's difficult to get them back over the cliff, if you will. Substantial deterioration, both neurobiological as also functional, social, has occurred. So in terms of the prodrome, the late prodrome is characterized by what are known as attenuated psychotic symptoms. Not quite delusions, but almost delusions. Not quite hallucinations, almost hallucinations. Disorganization of speech, thinking, but not so severe that you have a frank formal thought disorder. So this tends to occur on average about a year prior to the first psychotic break. And in DSM-5, an entity with clear criteria was laid out called attenuated psychosis syndrome. That is, individuals who are presenting with attenuated psychotic symptoms which have appeared or gotten worse in the past year. And there's no other explanation for them. No substance use, no other explanation for them. Now, what happens to these individuals? These individuals, at the end of a year, once you identify them, use the criteria strictly, at the end of a year, about a third of them have no diagnosis. There's no diagnosis. They seem to be similar to others in the unaffected population. About a third of them actually have a psychotic disorder, a diagnosed psychotic disorder at the end, by the end of a year. And about 75%, 3/4 of that is schizophrenia, the other quarter, mood disorder. Then a third basically are diagnosed with some non-psychotic disorder, obsessive compulsive disorder, major depressive disorder, other anxiety disorder. Now, what's critical here is if you look at these rates, the person that you've diagnosed with attenuated psychosis syndrome is about 500 times, 300 to 700 times more likely to manifest a psychotic break in the next year as compared to the general population. Now, that's a huge increase in risk. And so, obviously, in any medical condition, if you have that magnitude of risk, 500-fold greater risk of a really severe medical condition, and there's something that you can do that might make a difference in that period, you would want to try. And so attenuated psychosis syndrome can be fairly reliably identified. There are very strict criteria, and if you use them strictly, what you'll find is these are the transition rates. So what do you do if you identify a person with attenuated psychosis syndrome? you don't give them an antipsychotic. What you do at that point is monitor them very closely because they have this 500-fold greater risk of transition to psychosis. And if they transition to psychosis, treat them. Then at that time, treat them early so that you don't have a long lag, if you will. You don't have uncontrolled psychosis, which is bad for the brain, if you will, and obviously leads to worse functional outcomes. Secondly, 3/4 of those individuals have a concurrent other psychiatric disorder, depression, substance use disorder, anxiety disorder, 75% of them. Treat that aggressively. Treat that comorbidity aggressively. A number of studies have found that actually in that period, antidepressants are about as effective as antipsychotics in preventing transition to psychosis. So the critical thing there is treat that comorbidity aggressively and address any significant family conflicts, communication issues, and cannabis consumption in that period will substantially increase the risk of transition. And so this patient in particular, I'm going to counsel very strongly in terms of not doing anything else that might increase the risk of conversion. So there are things that one can do that really can make a huge difference, if you will. So that's the course of the illness. What about the nature in terms of clinical manifestations? Schizophrenia has at least 6 different symptom clusters, 6 different dimensions of the illness. Positive symptoms, delusions, hallucinations, paranoia. Negative symptoms, lack of motivation, reduced social drive, reduced ability to express emotion, disorganization of both speech and thinking, cognitive deficits. The average IQ of a person with schizophrenia is about 80 to 84. Broad intellectual impairment. And one way to think about that is, if this person did not have schizophrenia, on average, his or her IQ would have been about 16 points greater, if you will. Mood symptoms, very common and fairly severe in persons with schizophrenia. And they're severe enough that you would actually make a diagnosis of major depressive disorder, but for the fact that they have schizophrenia. And motor symptoms, often missed. Catatonia is the most extreme expression of motor symptoms, but motor symptoms are very common in persons with schizophrenia. Now, why is this useful for us to keep in mind, that you've got these 6 different dimensions? Well, firstly, because there are different brain circuits. All of them contribute to impairment, functional impairment. Firstly, there are different brain circuits, different brain abnormalities that underlie these dimensions. And even more importantly, as a clinician, these dimensions respond differently to treatment. Antipsychotics are pretty effective for positive symptoms and disorganization. They don't do anything for negative symptoms, cognitive symptoms. And they can both help and hurt mood symptoms and motor symptoms. So antipsychotics can be helpful in treating depression, but they can also cause depression, neuroleptic dysphoria. Antipsychotics can be useful in treating catatonia, but they can also cause the worst kind of catatonia, neuroleptic malignant syndrome. So it's really important to keep this fact in mind, that there are 6 different dimensions, all 6 of which are legitimate targets of treatment, because all 6 can contribute to patient dysfunction. And which ones are contributing to patient dysfunction or patient impairment, can vary from person to person. And another thing in DSM-5, it's in section 3 of DSM-5. I would strongly urge you to take a look at this particular scale. It's a very simple scale that's been put forth in DSM-5 to measure these 6 dimensions. So hallucinations and delusions to measure positive symptoms, disorganized speech to measure disorganization, abnormal psychomotor behavior to measure motor symptoms, measure of negative symptoms, measure of cognition, and then mood symptoms, measurement of depression, and measurement of mania. And it's a very simple scale, 0 to 4 for each of these 8 items. 0, clearly not present. 2 to 4, clearly present. 1, I can't really say if it's there or not. It seems to be there, but I'm not sure. That's a 1. 2 to 4, clearly present. 2, clearly present, mild. 3, clearly present, moderate. 4, clearly present, severe. And some of you are probably thinking, but isn't this a soft scale? Well, anchors are provided, clear anchors are provided in DSM-5 for each of these 8 items in terms of 0, 1, 2, 3, and 4. But even more importantly, once you begin using this instrument, you will get very comfortable and basically be fairly reliable to yourself, which is even more important because then this can be used to see what's getting better, what's not getting better. And that can inform better clinical decision making. So getting back to the course, and now we're going to be moving on to the chronic phase of the illness and what we're trying to do and what tools we have to do them. Getting back to this, much of the deterioration that you see in schizophrenia occurs early in the illness, during the prodrome, and in the first 3 to 5 years of the illness. And with each relapse in the first 3 to 5 years, you see damage to the brain, and you see a worsening course. So with each relapse, and you can see this on this graphic, that essentially with each relapse, you get progressive ventricular enlargement, and with each relapse, the illness becomes more difficult to treat. The same treatment that was working before the relapse may not work. Or if the same medication might be working, you'll have to use a higher dose of that medication. So relapses are toxic. Relapses, psychosis is toxic to the brain. So bear in mind, the natural course of the illness is relapsing and remitting. And with each relapse, you're getting worsening, if you will. So if you think about the importance of preventing relapses in schizophrenia, obviously during a relapse, the person is more psychotic, more disturbed, if you will, needs hospitalization. So bad things can happen acutely. The person is distressed, increased risk of suicide, increased risk of aggressive behavior during a psychotic relapse, and increased costs of care. And of course, whatever it is that they're doing, socially or functionally, occupationally, educationally, that's disrupted. So there are short-term problems associated with the relapse. But equally important are the long-term consequences. Each relapse leads to a further worsening, greater treatment refractoriness. It leads to worse functional outcomes. And so, again, relapse prevention is critical. So what do we know about the nature of schizophrenia? Well, we know there are multiple symptom dimensions, and that's important for us to keep in mind as we think about what we need to address in a particular patient. We know there are distinct phases of the illness, with much of the deterioration occurring particularly early in the illness. But relapses are bad all along, and so relapse prevention becomes important. So what are the goals? Now that we know the nature of the illness, what are the goals? Well, short term, when they're acutely ill, you want to kind of reduce symptoms. You want to make sure that the person is safe. So safety and reduction in symptoms is the principal goal. And the long term, relapse prevention, very, very important. Treatment of comorbid symptoms, whether it's depression or substance use or other, and minimize side effects. So those are the critical goals long term. And of course, do what you can to help the person function to the best of his or her capacity. So basic principles, and I'm going to repeat it a couple more times because I think this is really important, if you will. All our treatments, this is not just unique to schizophrenia, but I'm just discussing it with reference to schizophrenia today. Targeted treatment, measurement-based care, individualized treatment. And the tool for measurement is the instrument that I shared with you. So now that we know the nature of the disease that we are treating, how about the treatments we have at our disposal? So pharmacological agents pharmacotherapy is a foundation, and antipsychotics are the mainstay in terms of pharmacological treatment of schizophrenia. What do antipsychotics do? Well, antipsychotics do two very important things in the treatment of schizophrenia. They reduce acute symptoms, and as we discussed earlier, they're pretty effective for disorganization, positive symptoms. They don't do anything for negative symptoms, cognitive symptoms, and they can both help and hurt motor symptoms, mood symptoms. But as important, if not more important, antipsychotics are very important in reducing the risk of relapse. They reduce the risk of relapse by about 70%. Schizophrenia is a remitting, relapsing illness with incomplete remissions, with deterioration, worsening occurring with each relapse. Preventing relapse, very important, and antipsychotics are very effective in significantly reducing the risk of relapse, reducing it by almost 70%. So what antipsychotics do we have? There are 67 antipsychotics around the world. We have 20 antipsychotics available in our country. And you typically generally they're classified as typical and atypical antipsychotics. 8 of the agents are typical antipsychotics. 12 of these agents are classified as second generation or atypical antipsychotics. And the bottom line, what do we know about these agents? They're broadly equally effective. They're broadly equally effective with one very important exception. Clozapine is clearly more effective than all the other agents in treating patients who are refractory to other antipsychotics. Now, second generation antipsychotics on average have a significantly lower risk of EPS and tardive dyskinesia than first generation antipsychotics. On average, greater risk of metabolic side effects, but there's significant differences amongst both typical and atypical antipsychotics with regard to metabolic risk and other side effects. And individual patients may respond differently. So when we say that they're broadly equally effective, in a given patient, one agent can be much more effective than another. So in terms of the limitations of antipsychotics, they don't do much for negative symptoms, cognitive symptoms, and even as far as positive symptoms are concerned, they work, that's where they work the best. Sometimes they don't work fully. And functional social outcomes still need a lot in terms of improvement. They also cause significant side effects. And EPS is not, so with atypicals, second generation agents, the risk of EPS or extrapyramidal side effects is substantially lower. But it's not zero. And so even with any atypical antipsychotic, monitor for EPS. And why is EPS so important? Because if you can get a good antipsychotic effect without EPS, that's better for negative symptoms. That's better for cognition. That leads to a significantly lower risk of tardive dyskinesia. And obviously, the fact that you don't have EPS is a good thing in itself, and much less depression. So critical, when you're using any antipsychotic, you want to get a good antipsychotic effect, which you want to measure to see if you're getting the effect that you want, without EPS, without using an anticholinergic agent. Critical. Whether it's a typical or atypical, don't use an anticholinergic. If you find yourself having to use an anticholinergic, modify your treatment, because anticholinergics should be avoided. They make cognition worse, and if you're using an anticholinergic, that tardive dyskinesia benefit goes away as well. So again, why are atypicals? Why do we use atypicals more often than typicals? Why are atypicals about 92% of all the antipsychotics we use? Because they give you at least as good an antipsychotic effect with a significantly low risk of EPS. and that translates into these multiple benefits. So EPS, tardive dyskinesia, important. Metabolic side effects, very important as well. And then there are a whole slew of side effects, and different agents differ with regard to risk of side effects. But keep in mind that whether a side effect occurs or not depends on three factors. Certainly it depends on the agent that you're using, because the spectrum of side effects differs across agents. But it also depends on how you're using that agent, how rapidly you've gone up on the dose, what dose you're using, etc. And thirdly, it depends on the patient. Different patients are vulnerable to different side effects, and different side effects are more or less relevant to different patients. So when you're thinking of side effects, keep these three factors in mind as you're thinking about minimizing side effects. And so again, targeted treatment, measurement-based treatment, individualized treatment. Measure efficacy and see what's happening to those 6 dimensions. If something is getting better or something is not, then basically you can specifically target what's not getting better. So you can really inform your decision making by measuring these targets, if you will. So targeted treatment, measurement-based, also side effects, measure side effects, and then modify treatment, make appropriate clinical decisions. The third challenge with antipsychotics is more than half our patients don't take the medications as prescribed. And that leads, when they don't take their medications, that leads to higher mortality, that leads to recurrent relapses with all the problems that attend relapses, worse function. So essentially, relapse prevention, very important, and more than half our antipsychotics substantially reduce the risk of relapse, over 70%, yet more than half our patients don't take the medications as prescribed. And one of the problems with medications is if you don't take them, they don't work. And so the bottom line is non-adherence critical in terms of the adverse outcomes that one tends to see in schizophrenia. So we've known this for a while. So we've developed a number of very sophisticated methods to address this problem. Motivational interviewing, cognitive behavior therapy, adherence training, hand-holding, behavioral tailoring for each individual, reminder cues, encourage the patient to accept the disease and the benefits of treatment, educate the patient, family, and so lots of things. And so this cartoon, all these things that we've developed, these intricate kind of interventions, this cartoon serves to illustrate a problem. So the cartoon says, the patient's wife is talking to the doctor, and the doctor explains to her what she can do to help the person. She says, your husband is suffering from a very severe stress disorder. If you don't do the following, he will surely die. Each morning, fix him a healthy breakfast. Be pleasant at all times. For lunch, make him a nutritious meal. For dinner, prepare an especially nice meal. No chores for him, please, and no nagging at all. Oh, yes, and make love to him on demand several times a week. Do this for the next year, and he'll regain his health completely. So she goes, now that she's got this information from the doc, she goes out, and the husband asks her, what did the doctor say? You're going to die. Well, the bottom line here is, it's a problem which we need to address, but how do we address it? And Dr. Melnick is going to be sharing with you information about the best approach that we have in terms of addressing that challenge. So bottom line, what are we trying to do with persons with schizophrenia? How to help them? Well, the illness causes them to experience symptoms which interfere with their ability to do what they want to do in life. What's our objective? To do anything we can to help them be able to lead as meaningful and productive life as possible. And so we need to reduce the burden of disease. And we do it in one of three ways. We try and reduce the symptoms, treatment, medications, CBT, etc. We try to help them develop coping strategies to work around any symptoms, any deficits they might have, with rehabilitation, social skills training, etc. And then we provide supports to them, around them, supportive employment, supportive housing, etc. That helps them function better. But the problem is with each, anything that we do has some untoward effects as well. And so we add a treatment burden. So the bottom line is, how can we maximally reduce the disease burden while adding as little a treatment burden as possible? And in summary, one way to think about patients, this is an oversimplification, is let's think about three kinds of patients. There's one kind of patient who responds well and takes their medication, religiously. Another kind of patient who responds very well to antipsychotic treatment but does not take their medication. And a third kind of patient who takes the medication but is not responding well to antipsychotics. And broadly, an oral antipsychotic medication would work well for the first kind who responds well and takes the medication. Long-acting injectable, clearly, what's recommended for persons who are not taking their medications, although they respond well to treatment when they take it. And remember, that's about almost half the patients. And then as far as the medication not working, although the patient takes it, clozapine is the only agent that's been found to be more effective than others in helping persons with treatment-refractory schizophrenia. These are the Florida guidelines for treatment of schizophrenia. And the critical thing is, after you have tried a couple of agents and they've not worked, you must get to either clozapine or a long-acting injectable. If you suspect non-adherence, then a long-acting injectable. If it's clearly refractory, clozapine, but try both, if you will. We often get to unproven strategies such as combining antipsychotics, etc., long before we try these. So before you get to any of those heroic strategies, which really don't have much of an evidence base, but can sometimes be helpful, try the more proven strategies first. Clozapine, long-acting injectable. So in summary, we've made a lot of advances in our treatment of persons with schizophrenia, but still there are some challenges. They work pretty well for positive symptoms, disorganization. Negative symptoms, cognitive symptoms, still an unmet need, if you will. And one of the tragedies of schizophrenia is as longevity has increased for the general population, it has not for persons with schizophrenia. So actually the mortality gap has been increasing over the last 20 years for persons with schizophrenia. They die on average about 15 to 20 years earlier than the average person in the general population. A 20% increase in mortality, if you will, and a lot of that is cardiovascular mortality. And the functional outcomes still leave a lot to be desired. Less than 15% are fully employed and fully independent. So we've made advances, a lot that we can do, and a lot that we can do with the tools we have today. Treatment non-adherence is a huge problem which contributes to this mortality and morbidity. And Dr. Melnick will address some of the options we have in terms of addressing these challenges. So let me actually thank you all for your attention as I hand it over to Dr. Melnick. And please, we have plenty of time for questions, so please make a list of questions that you have, and there'll be people going around the room. Ivan?
Thank you. What an amazing overview in terms of understanding the world of schizophrenia. And, Dr. Tandon's done a great job of bringing this out. Today, we thought it would be a great option to go and talk a little bit about what options are actually in there. decided to do a history of long-acting injectables because we know that there's a huge need for understanding. A lot of times we get stuck in little ruts and we don't understand how all of these medications work. So actually one of the things that we did is we said, well, we're going to go through them one by one, kind of give a better overview of what they actually do. Knowing that we started dealing with injectables back in the 1960s. And yet, a lot of people still continue to practice 1960s medicine, especially in the older state hospitals. And what we're going to see is as we kind of go through with the advent of risperidone long-acting, everything kind of changed. But the paradigms really haven't. And I'm going to show you how we can, hopefully by the end you'll learn where we can change some of these paradigms in getting your patients better. So the first is understanding the use of first-generation antipsychotics. Henry Nasrallah recently published an article talking about 31 studies that show neurodegeneration with the use of first-generation antipsychotics. And the use of first-generation antipsychotic long-acting injectables, although still used, needs to change. We never would use a first-generation antipsychotic for a 24-year-old first break patient with schizophrenia, yet we consider using a typical injectable for an early intervention with a 24-year-old female with schizophrenia in a long-term chronic care facility. And so we need to start changing that mindset. So fluphenazine and haloperidol were pretty much done in the same way, in that they combine these medications with a sesame seed oil-based medication. And it's important to know that the oil is sesame seed, as 0.1% of the U.S. population actually has an anaphylactic allergy to it. One of the things that we started doing is actually documenting the fact that they don't have an allergy to sesame seeds in the record, just to make sure that we're getting ourselves covered. The way that these medications work is that they actually mix it with oil, they inject it into muscle tissue, understanding that oil and water don't mix. So what you're basically getting is this big ball of oil in the muscle, and as it compresses, it estrophizes, and it's doing so, pops off little bits of either fluphenazine or haloperidol over a period of about 2 to 4 weeks. And the idea behind this is, although you're still getting the medication, if you've used these long enough, you know that oil is a great medium for infection. And so there's actually a good chance of things like fistulas, granulomas, or even abscesses have been present in this. And one of the things that we know, again, because of the article written, there's a higher risk of brain atrophy. So we need to start changing that mindset and going at least into the world of second generations. So the first second generation was actually risperidone long-acting. It was FDA approved first for schizophrenia, then for bipolar disorder. It was the first water-based injectable. And the way that this worked was that they basically got a biodegradable microsphere of different thicknesses, and in the middle, basically having bits of risperidone. As injected into muscle tissue, over about 2 weeks, you get a first dissolving of the outer shell of the microsphere, and in doing so, again, bits of risperidone pop out. But there is a 2-week delay, and because of that, require about 21 days of oral supplementation of any antipsychotic needed. Injections given every 2 weeks, but again, that 2-week delay is important, especially if you're making titration changes. It could be either given gluteal or in the deltoid. It's processed primarily at the P450 at 2D6, and the most common adverse events at greater than 5% in the clinical trials, in the schizophrenia clinical trials, were headaches, Parkinsonism, dizziness, and akathisia. More recently, actually as of very recently, there's a new risperidone long-acting, which is now a subcutaneous. It was FDA approved for schizophrenia. Risperidone is both dissolved and suspended in a polymeric solution, and after the two are mixed and injected into the subcutaneous, it actually solidifies and becomes almost like an implant. Basically, the idea is over time that biodegradable subcutaneous implant starts dissolving and you get risperidone. One of the things is starts working very quickly, so actually you don't need a loading dose or you don't need any supplemental oral supplementation, and it's given every 4 weeks. It is given in the abdomen, which can be a little confusing for some of our patients that are used to getting it intramuscularly, as it is a subcutaneous injection. And this one's processed by 3A4 and 2D6, And the most common adverse events were weight gain, somnolence, sedation, and musculoskeletal pain. Paliperidone palmitate was FDA approved for schizophrenia and then later on for schizoaffective disorder. Water-based nanocrystal technology in which it requires a loading dose of giving an injection early of a higher dose, then a second dose about a week later. So in the first 2 weeks, you basically give 2 injections. Given every about 4 to 12 weeks, missed doses you have a 1 week plus or minus window, can be given either gluteal or deltoid. It is not processed in the P450 because it is the active metabolite of risperidone. The most common adverse events at greater than 5% and greater than placebo is injection site reactions, somnolence, dizziness, akathisia, and extrapyramidal disorders. Olanzapine Pamoate was FDA approved for schizophrenia, a rapid onset with no oral supplementation, given every 2 to 4 weeks. But the problem with this medication is that the Pamoate salt dissociates fairly consistently over about 28 days, but when mixed with blood, whether either go through a vessel or in a vessel or have nipped a vessel, the idea being that if you mix it with blood, it instantly disassociates the Pamoate salt from the olanzapine, increasing olanzapine's levels pretty quickly, giving a chance of post-injection delirium sedation syndrome, which basically comes as an olanzapine overdose or a cholinergic crisis. Because of this, the FDA requires a REMS, or a risk evaluation mitigation strategy, which requires a 3-hour observational period. Pharmacy, clinic, patient, and physician all need to be registered and work together to make this work, and requires us to report within a week of any PDSS events, which becomes very taxing, especially for clinics. But it is processed by 1A2, so it doesn't get processed by the normal, but 1A2 is where cigarette smoking does induce. And because of that, you have to be careful when stabilizing patients in an inpatient setting where smoking's not allowed, and then when they go out into the community, understanding you may drastically lower blood levels if the patient starts smoking. And the most common adverse events were headaches, sedation, weight gain, and cough. Aripiprazole monohydrate, FDA approved for both bipolar disorder and for schizophrenia. A water-based monohydrate aripiprazole. They basically got the molecule, they dehydrated it, added sterile water, and a preservative. Its long half-life, about 45 days, is the reason why it's long-acting and does not have a vehicle to make it long-acting. Because of its high affinity and starting right away, you can use any atypical antipsychotic or any typical antipsychotic for oral supplementation, and requires it for about 2 weeks. Given every 4 weeks, a missed dose gives you a -6 day or a plus 2 week period in which you can give it, and can go up to 3 weeks once you reach steady state. It can be given either deltoid or gluteal with low metabolic side effects, processed by 2D6 and 3A4, and the most common adverse events were weight gain, akathisia, injection site pain, and sedation. Aripiprazole Loroxil is FDA approved for schizophrenia, water-based prodrug of aripiprazole. The 3-week oral supplementation of aripiprazole is required, or more recently they started a new way of actually inducing it by using a nanocrystal formulation of the Loroxil of 675 milligrams, in which you give on day 1 with an oral dose, a one-time dose of 30 milligrams of aripiprazole, and you're able to get the blood levels within the first day. You're able to do that with the injection of the aripiprazole Loroxil long-term molecule, and with that, you're able to actually get from day 1 up to 2 months of medication into the system. With a low peak to trough ratio, the peaks and the trough are very close to the average. Low metabolic side effects. With a mixed dose you can use it as early as 2 weeks prior to your injection date, and up to 6 to 8 weeks, in showing one of the largest windows of all the atypical long-acting injectables. It's given every 4 to 8 weeks, depending on the dosing, and the most common adverse event was only akathisia. So those are the ones that are actually out that are actually available currently. More recently, we're going to start seeing some new changes in the long-acting injectable market, as there are some late-stage clinical developments. The first one is a 6-month polyurethane implant, similar to what they have for birth control, in which they actually put the implant in. This will actually allow 6-month use of risperidone over a period of time. Paliperidone palmitate is actually going into a 6-month formulation in which you'll be able to give the medication about twice a year. There's a risperidone in situ microparticles, which is also in phase 3. Well, this one's a once-monthly intramuscular formulation that doesn't require any oral supplementation. The biodegradation, actually, of this formulation happens very slowly, providing a sustained and controlled release for up to a month. And TV 46000 is also in phase 3, and this risperidone extended-release injectable suspension for subcutaneous as a maintenance treatment for adult patients with schizophrenia. So we see that there's a lot of options out there, and we need to see how we can actually use this. One of the things that I've learned recently is how early to use it. As Dr. Tandon said, as early as adolescence, you start seeing brain changes, and you start seeing changes as the brain starts shrinking from the outside. You don't just lose gray matter, but you lose the receptors onto which these medications can work with. And then later on, we learned also that with every relapse that occurs, you have widening of the ventricles and losing some of the cognitive thoughts. One of the things that we've also figured out early on is where this was happening is because we knew what it was called before it was called schizophrenia, which was dementia precox. The idea being that we knew that when people would do autopsies on these patients, their brains looked just like dementia patients, and yet they were not of the same age. So LAIs have been recommended in involuntary hospital stays for quite a while, with the goal of increasing treatment adherence among these patients with first episode schizophrenia and avoiding future deterioration. But the current guidelines regarding first episode schizophrenia have conservative positions, but more recent evidence, as I'll show you, has basically shown that this needs to be changed. Given the importance of continuous treatment in early phases of schizophrenia, long-acting injectables may be a viable treatment option, and the early use of these medications, and especially in the context of a shared decision-making approach, may reduce the negative image and the stigmatization of some of the attached long-acting injectables. Treatment of first episode schizophrenia is particularly important to improve long-term outcomes, as most clinical and psychosocial deterioration, cognitive decline happens within the first 5 years of the disease state. And many individuals' early stages don't accept their illness for themselves and the severity, and because of that, they have a false sense of being treated and being well. And because of that, they oftentimes don't want to be on medication. And the relapse rate in the first episode schizophrenia within the first year is well over 70%. So we need to do something to keep these patients well. In a cohort study with Theon, with about 2,500 patients with first-generation schizophrenia, found fewer than 50% of patients in the Finnish healthcare system continued treatment within the first 2 months of the initial hospitalization. That's only half. And this is in a group and in a country in which it is normal for us to really go out of their way to really go and get these patients to treatment as best they can. And in this study, route administration affected relapse. LAIs had 64% lower relapse rates than the oral medication that they were compared to. So the critical years are between first break and the first 5 to 10 years. That's it. Beyond that, they start becoming residual, and the chances of medications working gets lower and lower. And we got to start talking to them a little bit better in terms of getting these patients on long-acting injectables as early as possible. With the use of LAIs in first episode psychosis may be more effective than oral medication in controlling those patients and their relapses. And as we've learned, with every relapse that occurs, we don't just have worsening of brain, but it also takes them longer to get better. And it is generally accepted that long-acting injectables have a favorable side effect profile in comparison with their oral counterparts due to lower variation of peak to trough ratios. So one of the problems is how I was trained. I remember when I was doing my residency, I was told to use LAIs for the train wrecks, for the sick of the sick, for the ones that were the most non-compliant, for the ones that were the most chronic. And at the time, it kind of made a lot of sense. Because, when we had only haloperidol, pulixin decanoates, basically the idea being that we knew that once you started these medications, you pretty much committed them to a lifelong of EPS or some type of tardive dyskinesia. It's about 80%. So you had to really make sure that once you were going to go down that path, that you were going to do that. And I guess, were they right in making those kind of decisions and those statements? Well, they were right, but they were picking the wrong patient. You see, who are the patients with the poorest amount of insight? Who really don't know that they're sick? The patients that are early in the disease state who truly believe God's still talking to them? Or the patients that have been sick for 20 years and say, well, I'm a schizophrenic and I hear voices? The answer's early. And if we know that's true, then who are the patients who are the most non-compliant? Now, don't get me wrong, they're all non-compliant, right? But who are the ones that actually stop their medications because they feel cured or they feel well? And the answer is the ones that are early in the disease state. And if we know that's true, then who are the ones that are most likely to accept injectables? You know, for years, pharmaceutical companies have come to us and said, doctor, the reason why you don't use injectables is because you don't ask your patients. And we say, no, we ask our patients, but they always say no. Isn't it funny, the ones that always say no are the guys with like 30 tattoos, 15 piercings, and tell you they're scared of needles, right? It's amazing. It's amazing. But the problem is we're asking two completely different populations. You see, we were trained to go out and talk to the patients who have been sick for 20 years. That guy's probably been held down by 30 other people, given, 5 other people given a 5 and 2 of Haldol and Ativan as a punitive measure. Has been told he's a bad patient, he's non-compliant. The pharmaceutical company goes to the 20-year-old who's been hearing the voice of the devil for the past 3 weeks, terrified, been in a hospital setting. And they go out and they say, what if we gave you an option that will hopefully get you stable, keep you out of the hospital, and prevent this from happening, and hopefully give you the best chance of long-term outcomes? Who's most likely to accept that? The answer still comes to early. And if we know that's true, then who are the patients with the healthiest brains, with the most amount of receptors, who respond best to the lowest amount of medication and have the best chance of long-term outcomes? It still goes back to early. So we need to start changing that mindset of waiting till later into the disease state and starting to use them as early as first or second episodes and trying to make these patients better. There are a lot of advantages of using LAIs. There's no need for daily administration. I remember one of my patients early on and I've told this story before, but early on where basically he had been he'd come in with a psychosis, hearing voices. Finally got him better and stable, and he came to me about 6 months after being on a long-acting injectable and talked about how it changed his life. And I said, well, how did that happen? He said, well, every day I took a pill, it reminded me of being sick. Every day that I had friends come over the house, I was worried that someone would find my medication and know that I had a mental illness. We live in this world of stigma, and the problem is that medications, especially pills, really bring that out. LAIs actually help the stigma, and we'll talk about that later on. There's a guaranteed admission and transparency of adherence. Well, if relapse occurs, we know that it happens beyond this. There was a study out of Thailand that showed that using LAIs, especially in a larger group of patients, actually improved doctor-patient compliance because we could trust our patients into taking these medications. There were lower relapse rates, minimal GI absorption problems, circumventing first-pass metabolism. There's consistent bioavailability, more predictable concentration, a correlation between dosing and plasma levels, reduced peak through trough plasma levels, improved patient physician satisfaction, improved patient outcomes. I mean, these things are happening. There are some disadvantages. There is a slow titration. Nothing happens quickly with an LAI. Long time for achieve steady state levels, oftentimes 2 or 3 injection cycles. Less flexibility or dose adjustment for good responders. Delayed disappearance of distressing or adverse events. Once you stop the medication, it does take a little while for it to kind of go away. Pain at the injection site may occur, especially in the oil-based LAIs. Risperidone LAI requires refrigeration, as it is a biodegradable substance, may be cumbersome, and actually we've had issues where we had to use a whole refrigerator specifically for it, and the perception of stigma. We actually cause some of that stigma as we go through. Some of the current recommendations is that LAI should not be restricted to patients with adherence problems. As I'll show you later on, it actually has nothing to do with it. LAI should be systematically offered to all patients through shared decision-making. Patients whose long-term treatment is using these medications should be considered as an LAI, as this will give them the best chance of long-term outcomes. And even if a patient initially refuses, my wife constantly will come out and change her shirt, telling me she doesn't like the way she looks at that moment in time. It doesn't mean she hates the shirt. Just because she doesn't go out, and just because someone refuses an LAI doesn't mean later on they may not be a good candidate for it again. So we go back to the idea that treating LAIs as early as possible from the first episode can reduce relapse, number, duration of rehospitalization, cognitive symptoms, and the most important, can improve quality of life. What is our true goal of treatment? It's to give life back to some of these patients that truthfully a lot of them have not had for many years. And we're able to do this with an LAI. So we know that relapse is common. About 82% of patients with schizophrenia or schizoaffective disorder experience at least one relapse over 5 years. Relapse can cause rehospitalization, slow, incomplete recovery, cause cognitive deficits, and reduce, again, that quality of life. And when they did a study comparing oral versus a long-acting injectable of the exact same medication, they found that LAI patients had fewer relapse than people on the exact same molecule in dealing with long-acting injectables. And when you do mirror image studies, LAIs reduce the risk of hospitalizations. What's the most expensive piece of psychiatric care? And it's 1 day in the hospital costs roughly about 1 month's worth of medications. And we've got to really start making these changes. And there is no difference in terms of relapse or discontinuation using LAIs or oral medications, which basically means they have similar adverse event profiles and the discontinuations are very similar. So despite helping patients stay out of hospitals, helping them keep their brains healthier, there is no difference in terms of adverse events or anything like that. So strategies for initiating. Fundamental challenge, right, is the active agent in both oral and long-acting formulations are the same. So the actual antipsychotic molecule is exactly the same thing. If a patient takes the oral formulation exactly as prescribed, the outcomes should be similar. The problem, well, that doesn't always happen. And because we know that less than half of the patients take the oral formulations as prescribed, we need to do something to help adherence with these patients that have a primary thought disorder. And there's a huge misconception with the use of LAIs. Show of hands, how many of y'all believe long-acting injectables improve compliance or adherence? Great. How many of y'all ever heard the term leading question? Right? The idea is they actually don't improve compliance or adherence. The definition of adherence, if I give you a pill today, what are the chances you're going to take a pill tomorrow? If I give you a shot today, what are the chances a month from now you're going to come back and get a shot? Doesn't get any better. What it gives you is it gives you the assurance of adherence. If I give you an injection today, then I know you're being adherent. If you don't come in for your injection today, well, then I know you're being non-adherent. It gives us that understanding of where this actually lies. And you're dealing with people with a primary thought disorder. I mean, patients with schizophrenia, these people have a hard time making decisions on a daily basis, like taking a shower every day. And yet we're entrusting them with taking a pill 365 times a year. And despite that, they rarely able to do that. Taking a shot once a month, that number gets cut down to 13. Going to every 2 months, it's now to 6. Every 3 months, it's even less. And now we're going to do every 6 months. The idea being that giving them a chance is much more easier for a patient to make these decisions if they're giving an opportunity in which they're able to make that happen. Now, Dr. Wyden did an amazing study which basically asked the question, why do patients not want to use long-acting injectables? And what we found is that it's actually our fault. You know, a lot of times we use our own stigma, our own ideas of how we should use long-acting injectables, whether it's using them late or using it with the very sick or with the very chronic. We hear things like, you're not sick enough to be on an LAI, or, you're not too far down the path, or you're too young to use them. Research suggests that if you offer LAI therapy itself, often characterized by hesitation by what we do, we need to start changing that mindset. Patients might have accepted an LAI therapy if they've been presented it differently. And in this study, they interviewed a bunch of clinicians, and they said, try to get your patients to use an LAI. And when they did, they found out that the vast majority of them actually were not accepting of an LAI. They went back and they looked at the transcripts. And in looking at the transcripts, they went and they saw that the way that we were asking for things like, you don't want a shot, do you? Or you're not sick enough. True story. And what they found is once they retrained the clinicians, the acceptance rate went way up. The idea is we got to start making these changes early on. So we have some clinical case examples. One of the ones that we're going to talk about, or Doc is going to talk about, is Jack.
So this is Jack. Now, Jack is a 33-year-old gentleman with a long history of paranoid schizophrenia. He was first admitted to the hospital in 2007, so that's 11 years ago when he was 22. And now he is doing really badly. He's decompensated and been admitted about 15 times in the past 5 years. And he's tried to commit suicide 3 times with an overdose. He also has, in addition to schizophrenia that's not poorly responsive to treatment, he also has intermittent depression, psychogenic polydipsia, and currently he's receiving treatment with haloperidol, long-acting haloperidol, in combination with high doses of quetiapine, 800 milligrams. He's had trials, adequate trials, long trials, with olanzapine, quetiapine, risperidone, aripiprazole, haloperidol, and he's getting a whole bunch of medications at present in addition to the injectable haloperidol and quetiapine. He's getting benztropine, fluoxetine. He was getting nifazodone when that was available. Now he's getting trazodone, sertraline, divalproex, and lorazepam. So this is a challenging case, actually similar to a couple of cases that you've shared with me. What should you do? So should you continue this? I mean, you've tried everything else almost, haven't you? I mean, so what would you do? I'm sorry? Oh my God, I mean, forget about everything else. Actually, since you said clozapine is absolutely the right thing to do in this case for several reasons. Actually, there are several things that are pointing to clozapine here. One, treatment refractory for sure. Suicidality. Clozapine is the only antipsychotic that has an additional indication for treatment of suicidality. Psychogenic polydipsia, water intoxication. Clozapine has application there. So clozapine, for a variety of reasons, is exactly what you should be doing in this particular patient. And now the challenge really is that we don't use clozapine very much. You know, our use of clozapine around the country, it's about 3% of persons with schizophrenia receive clozapine. And when probably about 15 to 20% should be on clozapine, and probably a greater proportion should have received a trial of clozapine. Now, by the way, how many of you are from Florida? Ah, okay. So Florida is particularly bad. The use of clozapine in Florida, 2%. And so it's not utilized much. For that matter, long-acting injectables are also not utilized a whole lot. And there are a lot, we'll get to the question that you've raised. Actually, these are some of the questions that you have raised. Do you want to kind of go to the next one?
Sure. So this is Miss Jones. So this is actually a true patient from my forensic program. First met her at the state hospital when I was a resident, 21-year-old female with no previous psychosis, but had acted strange in the past. She's a high school graduate and was in college with no previous drug use and rarely drinks more than a few drinks a month. Her initial presentation was brought to the jail after she killed her boyfriend. She was previously on Olanzapine to control some of those strange thoughts that she had in the past, and she was having when she was seen when she was 20 years old. She would feel the TV would giving her messages, and that the Olanzapine kept those thoughts under control. She was quite stable on the current medications. Her boyfriend told her that she was gaining too much weight on her medication and that she didn't need it anymore because she didn't really have any symptoms. You've heard this story before, right? Yeah. Without telling her doctor, she decided to stop her medication. After a few weeks, she didn't recognize that she was beginning to hear voices again. And she was getting messages from the TV. One of those messages would tell her that the end of the world was coming and that she was chosen to do battle with the devil. One afternoon, she was watching a TV program and, she got a signal to do battle. And while watching the local news, according to the message, the devil took the image and the shape of her boyfriend, and it was her job to kill the devil. She went, she grabbed her guitar, hit him over the head with it, realized that he was just unconscious. She went, she grabbed a kitchen knife, and then gutted him from neck to pubis, took out his organs, put them all over in some ritualistic manner. She then proceeded to call the police across the street and said, "I would like to speak to the mayor." When the police said, "Why?" And they said, "Well, because I just killed the devil and I would like a parade." True story, I actually was part of the forensic group afterwards and got a chance to see some of it. It's pretty horrific. But this woman actually didn't think she did anything wrong. She was found not guilty of reason of insanity, spent 3 years in the Forensic State Hospital here in Florida, received oral medications, and she would get transitioned to the less restrictive environment. She was often caught cheeking her medications. When asked why, she replied, because she was cured of her illness. She went to the outpatient, finally transitioned to my forensic community control program, where we started on an LAI. We began the conversation about using an LAI, talking about her goals. She always wanted to go back to school. She always wanted to get married and have a boyfriend. She told me that she wanted to go and get a job. We talked about outcomes. We talked about what the best results and being consistent, predictable blood levels gave her that best chance of those outcomes. I explained to her that the medications were only as powerful as the lowest part of the trough, right? It has many side effects as its highest peak. And so a lot of the side effects that she was complaining about, if we were able to lower the peaks and raise the troughs, we would give them the best chance of good outcomes as well. And it would also cut down the times that you need to take medications from 365 times a year to 13 injections a year. She accepted, and ever since she's been stable. She's been on an LAI since coming into our program. She completed vocational school, now working as a secretary at a local company. She has good conversations with her family. This is a person who honestly was very much isolating most of her life. No longer feels paranoid about her environment, no longer gets messages from the TV. Gave her a better quality of life. We talk about what is our true goal of treatment, and it's functionality. We gave her that too. She's no longer psychotic, no longer dangerous herself and others. She's successfully integrated back into community. LAIs gave her freedom from not taking medications on a daily basis. And she's now being trusted by the court to live independently. And she's able to do that because we're able to assure the court that she's taking medications. See, LAIs aren't just for the sick of the sick. It's not for the guys that have been sick for 20 years. It's for those 20-year-old women that really need the help to get better. It's for those 30-year-old males that are just lost their way and just very psychotic, but they're able to respond well to these medications because their brains are still healthy. We can't wait too long into this to make this happen. One of the things that we always talk about are the ideas of a good discharge plan too. Living arrangements are important, social support. One of the problems that we've had for years is that we just kick people out into community from hospital settings and not really do a great job of that. Daily activities such as teaching them about how to work or cooking, cleaning, budgeting money. Medical plans, right? Making sure that they're able to get their prescriptions and able to find ways to get their medications covered by insurance companies or patient assistance programs. And community treatment plans. Find some case managers that might be able to help you. A lot of ACT teams work well with this. It's vital that we use the resources that we have in our community to make this happen.
We've got some outstanding questions, which I think will help us get a better understanding of the subject. One question, Where is that instrument in DSM-5, that symptom assessment instrument? Please, thanks, is the question. Well, it's in section 3, so it's not in that small, diary kind of thing. It's in the big manual.
It's not the
It's
pocket
in section
guide.
3, not the pocket one. It's not pocket DSM-5. You won't see it, but it's in the big section 3 is at the back of the manual before the appendix, if you will. So that's one of the things in DSM-5, by the way, that they added a section 3. Earlier, in all the other DSMs, you just had 1 and 2, and then the appendix. They've added a new section in DSM-5, section 3. Let me take a couple of questions on tardive dyskinesia. So what proportion of patients on a first-generation antipsychotic will develop tardive dyskinesia? Now, again, if you develop EPS early, 5-fold greater risk of developing tardive dyskinesia. Tardive dyskinesia is not this completely irreversible monster that once you have it, it continues. It fluctuates. Although with continuing use, it tends to get worse. The prevalence increases, but you can lose it too once you develop it. So it's not something that always stays with you once you get it. Roughly, it's about 20% or so with atypical antipsychotics. It's about 1/5. The prevalence decreases by over 80%. So it depends on the age. So older patients, higher risk of tardive dyskinesia. But even in the elderly, you see an 80% reduction in the risk of tardive dyskinesia as compared to typicals. What about long-acting injectables versus oral agents with regard to tardive dyskinesia? It depends on the agent that you're using. The studies that have been done thus far don't find a difference between long-acting injectables and oral with regard to risk of tardive dyskinesia. It's certainly not greater. Theoretically, one might even suggest that it should be lower because with the injectable, you get a much narrower range in terms of levels, if you will. So you don't get this withdrawal, which is part of the factor, this up and down in terms of occupancy that you get with orals. But in terms of data, no difference between oral and injectable for the same agent, if you will. Alan, do you want to take?
Yeah, sure. So here, this one I thought would be great for you.
Okay.
Yeah, it's interesting. Anyway, how do you overcome patients' fear of LAIs regarding needles and amount of medication put into their body at one time? Part of it is understanding exactly what you're getting. Knowing that the medications oftentimes are using delivery systems to make this happen. You don't just get this big rush of medication. It's communication. It's understanding that when you talk to a patient, you tell them, for example, the average dose per day cannot be more than the maximum oral doses, or else it would never have been approved. So that's the first thing to get with that. Other is confidence. It's building that trust with the patient. Discussing with them that this is the best way to get an average dose that's going to be better with a peak to trough ratio that's going to give you best chance of long-term outcomes. I always begin my conversations with outcome measures. I always ask them, what are your goals in life? I ask them, what is it that you want to do? And they usually will tell me, I want to get married, have kids, I want to go to school, I want to get a job, whatever it might be. And I tell them, I said, the studies have all shown that this will give you the best chance of achieving those goals. The idea of the needle, in talking to them about the fact that you're going to be getting it once a month, talking to them that the newer medications are all water-based and the water absorbs very quickly and shouldn't really cause that much discomfort after the first hour or so. Those kind of things are great ways to discuss it. Other questions are treatment of akathisia. Depends on the akathisia that we're talking about. D2 partial agonists have a different akathisia than D2 antagonists. It has to do with the activation of the D2 receptor versus the blocking of the D2 receptor long term. The ones that are D2 antagonists, oftentimes we use medications such as cogentin or artane. It's been traditionally used for partial agonists that you use things like beta blockers and benzodiazepines. And do you think that APA will change the guidelines for LAIs as first episode? It's unlikely, only because when they do these studies, pharmaceutical companies can't use first break schizophrenia in their patient types because we technically don't know that a first break schizophrenia is having a first break schizophrenia until later on, as it could just be a brief psychotic disorder. So the idea being that they usually weed out those patients that would have been a first break. So because of that, the data is only data that investigator-initiated studies, which I know Dr. John Kane's doing at Long Island Jewish, and there's a bunch of other people that are doing as well. And possibly over time, when that group of those numbers actually get to a point where we're able to see it, then hopefully we'll be able to change the guidelines.
On that note, let me take the next one. What theoretical basis could underlie trying a long-acting antipsychotic after 2 short-acting oral failures rather than going to clozapine? And the answer really here is, if they were full-fledged trials of the agent and there was clear non-response, and the person, you have no question about adherence, absolutely go to try clozapine. But the reason to try a long-acting injectable is because non-adherence could be a factor, might be a significant factor. It is in many patients, and so that's the reason. But definitely before you get to polypharmacy and things of that sort, try both, if you will. And the other thing is, if about almost half the patients respond well but don't take the medications, why aren't long-acting injectables not used more often? Exactly. And I think, Dr. Melnick discussed some of the reasons why we don't. And I think it's really important to keep this one fact in mind. That is, our thinking and how we communicate to our patients is the critical factor. If you don't believe that long-acting injectables provide significant advantages, you will not offer them to all your patients. You will only utilize them as a strategy of last resort, which is not what one should do. But the first thing really is what you believe. And look at the data, and once you formulate your belief, communicate clearly with your patient. And what you'll find is many of your patients, not necessarily all, but most of a majority, will actually welcome a discussion of the pros and cons of a long-acting agent. Let me take another question with regard to, and there are 3 or 4 questions, actually 4 questions regarding anticholinergics, if you will. Well, one question is, well, if EPS is the issue, then why don't you just start off adding an anticholinergic with the antipsychotic? The issue here is never use an anticholinergic chronically. So what do I do if a patient develops EPS? I do use an anticholinergic short term because I don't want the person to experience Parkinsonian symptoms, but I will not use it long term because it's bad for cognition, it's bad for tardive dyskinesia. It essentially reduces the benefits of the antipsychotic, makes those worse. That's why I will not use an anticholinergic chronically. But acutely, if someone develops EPS, I will basically treat the EPS with the anticholinergic, then making some changes in terms of the other antipsychotic regimen. Go ahead.
All right, and lastly, because I know we only have about 10 seconds left, for a psychiatrist who's with a private practice, where could you refer to administer the medication? It's interesting, in some states, depending on what state you're in, some states actually the pharmacists are actually able to give the long-acting injectables. In other areas, if you talk to some of the drug companies have made alliances with certain clinics in where you're actually able to go to send your patients to those clinics to get their injections. What we do oftentimes in my private practice when I can't is that we will actually send them to their primary care. They're more used to giving a lot of injections as well, and if you have a good relationship with their primary care doc, they oftentimes will help you out in having their nursing staff give it. Thank you guys very much for being here. We really appreciate it, and we'll be around if you have any other questions.
Thank you.